We want to welcome everybody to Traumatic Brain Injury, What Your Client Needs You to Know. This is presented by Nirmala Dhar. Nirmala is a powerhouse in the world of older adult behavioral health. If you are not familiar with Nirmala, let me just read you a little bit of her bio. And I think I'm actually on video, aren't I? Okay, well, hello. Nirmala is a licensed clinical social worker with a master's degree from the George Warren Brown School of Social Work, Washington University, St. Louis, Missouri, and Bombay University, India. She's mission-driven and has 35 years of experience in behavioral health in the public sector in Missouri, New Jersey, and Oregon. She's the Older Adult Behavioral Health Services Coordinator for Oregon Health Authority's Health Systems Division. In this role, she's the Older Adult Behavioral Health Initiative Project Director and PASSAR Level 2 Program Coordinator and Subject Matter Expert and SME for the division. She's the OHA champion for the Geriatric Behavioral Health Echo Clinic for nursing facilities. And prior to this position, she worked for Clackamas County Behavioral Health for 18 years. This included 10 years as the only geriatric mental health specialist, clinical program supervisor of the community support team, and as a policy analyst on the health administration team. She's a trainer and presenter on behavioral health and aging topics and is a CIT trainer. Her areas of professional interest include improving behavioral health access in long-term care settings, positive aging and age pride, social justice, quality improvement, health metrics, and workforce development. And after all that, in her spare time, she enjoys mentoring younger professionals who share her values, gardening, reading nonfiction, and traveling. This woman is very well-rounded. She also considers herself a foodie, is married to Sanjay for, I want to say, close to 40 years now, and lives in Lake Oswego. So we are thrilled once again to have Nirmala with us. She's always a fascinating trainer. And let me give you a little bit of the housekeeping piece. We're able to bring this to you because of joint efforts out of the Older Adult Behavioral Health Initiative. This initiative is statewide and allows us to provide you through partnerships with free CMEs, free trainings. Our upcoming trainings, our first one will be September 18th with Terry Schroeder on civil commitment. For this training, you need to know that you need to set up an EADS account. You need to go to eeds.com and set up an account if you don't already have one. This takes about 24 hours to kick in for the new accounts. So don't be surprised if this is your first time and you're not able to access anything. We're working on getting that, the period of access lengthened. So EADS meeting number is 14-NEWS. 14, N for Nancy, E for Echo, W for William, S for Sam. 14-NEWS, that is your code. I would say go in there right now, put your screens on minimize and get into EADS and check in so that you get full credit. You should have in your reminders gotten some information on how to print out your certificates. As always, if you get stuck, we will try and help you figure out the system. So that said, why don't we turn this over to Nirmala, who's going to take us on a 2-hour journey.
So my topic today is, what you should know to help your client. And that's exactly what the poll question, the last poll question indicated, that you all, 70% of you said, hey, we need help. Next slide. And so, so these are my learning, next slide, please. My learning objectives for today, and by the way, you will all be getting the slide deck, so rest assured it will be mailed to you along with other supporting documents that I have put together for you in terms of.
Nirmala, this,
Yes?
this is Angela. Let me just interject. This is why we need everybody to get an EADS account, because we store the PowerPoints of all of our trainings on the EADS system. So we need you to do an EADS account. And yes, anything that Nirmala would like, adjunctive handouts, we will get that to you after the training. Thanks.
Okay. Thank you. So my learning objectives for today are that you will learn a definition of what traumatic brain injury is. You will learn how people assess for the severity of brain injury. And then, very important for the audience today, what is the importance of screening for brain injury? All of you, that's going to be directed towards you. And then the bulk of my training is really going to be around knowledge of the cognitive and executive functioning impacts from brain injury. This is where the rubber hits the road in terms of all of you. How can I help my client, my consumer with brain injury? So what do you need to know and how can you help? And I'm not going to focus today on the psychiatric sequelae or impacts of traumatic brain injury. My focus is really going to be on brain dysfunction. If you would like on psychiatric comorbidities with trauma, with brain trauma, you can let Angela know and we can come back and give that training. Then you will also learn about specific interventions. And lastly, you will get resources. And I have a separate document with resources, which I'm hoping you all will be very excited to look at and explore once you get it. Next slide. So what is brain injury? This is the definition part. A traumatic brain injury is caused by a bump, blow, jolt to the head, or it is caused by a penetrating head injury that disrupts the function of the brain. So very important. It's a bump, blow, jolt to the head, or it could be some kind of physical implement or something penetrating your brain, actually physically penetrating your brain causing injury that disrupts the functioning of your brain. It is caused by an external physical force to the head, whether it is you bump your head when you fall, or you're in a car accident and you hit your head on the steering wheel, or you fall backwards and hit your head. It can be any number of things. The severity of the injury to the brain ranges from mild and undetected, sometimes it's totally undetected, to severe and life-threatening, where people actually are in coma and kind of go into a vegetative state. So it's kind of the full continuum. More importantly to note too, not all blows and jolts to the head result in a TBI. Okay, so this is kind of the basic information definition, which I'd like to keep, like you all to keep at the back of your head. Bump, blow, jolt, penetrating head injury caused by an external force to the head, which disrupts the functioning of the brain. Next slide. So there are many types of head injuries, which we just talked about, So some are called closed head injuries. Many of you have heard of contusion and concussion, he had a concussive injury. Very often, athletes experience that. The other one is called coup contra coup. Coup means essentially that the injury occurs on the site of the impact with the object. So if you hit your forehead, the front of your head in a motor vehicle accident on the steering wheel, the injury will be at the site where you hit your head. A contra coup is where the injury actually happens at the opposite opposite to the site of injury. This is really where your brain is kind of moving, accelerating, deaccelerating in your skull, so that even though the impact is maybe in the front, but the injury happens at the back. And that is called contra-coup in it, the head injury. Sometimes it can be caused by blood flow and metabolic changes. Cerebral edema, you all may know of, that famous actress who died from a skiing accident. She hit her head and, she had blood flow and cerebral edema that put pressure on her brain. And, she died from that injury within 3 days, Natasha Richardson. And then I'm going to talk briefly about these other kinds, diffuse axonal injury and blast injury. And then we have open head injury. So the above ones were all the different kinds of closed head injuries. Next slide. So remember I talked about traumatic brain injury. We can see it on a continuum of severity from mild, moderate to severe. So how do we determine, what is mild and what is severe? So for mild traumatic brain injury, there is often no, LOC stands for loss of consciousness. So there's no loss of consciousness, or if there was, it's less than 30 minutes. So that's the marker for mild traumatic brain injury. So less than 30 minutes of loss of consciousness. For moderate traumatic brain injury, the loss of consciousness is 30 minutes to 24 hours. So you've lost consciousness. And for severe, of course, the loss of consciousness is 24 hours or more. It can also result in a coma. All of these cause temporary or permanent effects. And TBIs also have a cumulative effect. That means the number of TBIs you've had. And very importantly, for many of you who are parents, TBI at a young age can affect development. So all of you who work with people with brain injury, traumatic brain injury, a good thing would be to look at their medical records and see whether their head injury is mild, moderate, and severe. And this is one way to question, how long did you lose consciousness? Does he or she remember? Or can a family member tell you? Or you're seeing it in the medical record? That would be a very good indicator about the severity. So that is the severity index. And then we look at what I call the fingerprint of TBI. What is the signature of TBI, which is injury to the front part of the brain, frontal and temporal lobes. And we are going to see many pictures of the brain. So I'm hoping by the end of this session, you have a good handle on, what are the different parts of the brain. But essentially, the front of the brain gets injured. That's the typical fingerprint of TBI. So we call those the frontal and the temporal lobes. And what gets affected is emotional and behavioral regulation. Why? Because they reside in the frontal lobes. Next slide. So here it is. Can you see that red part of the brain? Actually, a good way to illustrate it is just raise your hand, your arm, and make your hand into a fist with your thumb over your fingers, and it gives you a really good picture of the brain. Easy way to work with your clients when you're trying to show the brain. And that's the front of the brain, the red part, and then the purple part is the temporal lobes. So these two areas most often get affected in a traumatic brain injury. And we are going to talk about why am I emphasizing this so much? Remember in coup, contra coup injuries, the back of the brain or the side of the brain can also get affected. But the most common one, or what we call fingerprint, is these two areas, the front of the brain. Next slide. I thick. So I'm just giving you some, showing you some pictures of, what a contusion or a concussion looks like. It is like bruising to the brain, which causes, remember I said less than 30 minutes loss of consciousness, or actually no loss of consciousness. And it can cause headaches, nausea, some dizziness, some problems with concentration. I remember one of my colleagues was in a car accident where he had a slight hit his head and a little bit of whiplash, and he thought he was fine and came to work, and he was experiencing headaches and nausea, and he went to the doctor and they said, you have a concussive injury, and he wasn't even aware because he hadn't lost consciousness. So it's mild injury. Next slide. And here I'm just showing you how your head strikes an object. This is what concussion looks like. The front of the brain hits your head right in the front. Next slide. We talked, there was one section on that closed head injury, which I call diffuse axonal injury. Here, the brain does not require actually a direct head impact. But what happens is during rapid, it could be, you're in a blast zone or something. What happens is there's rapid acceleration of the head, and some parts of the brain move separately from other parts. This type of motions can destroy axion. Just the sheer force of that movement can destroy axions in your brain, which are necessary for brain functioning. And these shear forces can stretch the nerve bundles of the brain, causing damage. I'm not in any way expecting you to remember all of this. It is for you to really explore it with your clients. What kind of injury did you get? How long did you lose consciousness? Where did you get the injury? Those should be all of the key questions that you should be asking your client. Next slide. This is very common in our veterans, and Oregon has a large number of veterans, and actually across America, who have had traumatic brain injury. In fact, it's considered the signature injury of the war. Blast injuries are the #1 cause of injury of death in Iraq. And look at that. 85% of TBIs are closed head injuries. So, their brains were affected during the blast injury. So very important if you're working with veterans. Next slide. So what, again, I want to reiterate what mild traumatic brain injury is. It is a concussion which results from a blow to the head and causes the brain to strike the skull, whether it is sports or it is a car accident or you fell forward and hit your head on the pavement. Generally, there's no major structural damage to the brain, occurs with or without loss of consciousness. So that's why you should ask your client or a family member. Remember, less than 30 minutes or no loss of consciousness. And these are sometimes called acceleration, de-acceleration injuries, in terms of, your head goes forward, it can snap back, and your brain is actually, accelerating and de-accelerating also in your head. And sometimes we miss these injuries because they're sometimes called, they're not very visible. Sometimes TBI is called invisible, and we want to change that because it has a profound impact on people's lives. And that, like I said, it can go undetected for many, many years. People are wondering, what's wrong with me? What's wrong with him? And nobody asked or screened the person for traumatic brain injury. Next slide. And I just mentioned that this kind of injury, TBI, is the signature injury or disability of the current war. Signature injury. And in the war zone, the injury was caused by sudden explosions from, all of us heard about IEDs, explosive, improvised explosive devices, rocket-propelled grenades, landmines, roadside bombs. And many of our military veterans had been exposed to 6 and maybe as high as 20 blasts. So this is the signature disability of our current war. Next slide. So most individuals who sustain a mild traumatic brain injury recover within, say, 3 to 6 months. About a fourth of them go on to experience more persistent symptoms. And what is the best intervention? Psychoeducation and promoting expectations of recovery, that is giving hope, is the most effective intervention for preventing persistent symptoms. So got it? Psychoeducation and promoting expectations of recovery. Yes, small portion go on to experience persistent symptoms. And sometimes it's compounded with psychiatric comorbidities, which we are not going to cover today just because of our time. Next slide. So in moderate to severe, the patient experiences any of the following: is knocked out or blacks out for more than 30 minutes, has memory loss, is confused for hours, days, or weeks. And remember, in some severe traumatic brain injury, you can be in a coma for an extended period of time, and some also slip into a vegetative state. But basically, it is blackout. You're knocked out, have a blackout of more than 30 minutes. And very important, they have an abnormal brain scan, whether it is a CT scan or an MRI. So any of you working with people with traumatic brain injury who have had it for some time and you're trying to figure out, hey, when did you get it? What's the severity? Check the medical records. Was a brain scan ever done? What were the results of the brain scan? And ask those questions about how long were you knocked out? How long did you black out? How long did you lose your memory or were confused? All of those are key in helping you help your client. Next slide. So what are the signs and symptoms of moderate to severe TBI? Look at in physical. You have headaches, sleep problems, dizziness, balance problems, this chronic kind of fatigue, sexual dysfunction. You may develop a seizure disorder. You may have sensory changes like in your taste or in your hearing and vision, and then loss of strength. Look at emotional. You may experience depression, anxiety, irritability, mood swings. That means your mood is very labile. You're high and you're low and you're irritable, all on that continuum. You may exhibit very inappropriate behavior, like socially inappropriate. You may act extremely impulsively, and we're going to talk about all of this. And you're really acting out of character. This is not you. And then there is cognitive, which is, we are going to focus today on cognitive and that emotional aspect. Confusion, agitation. You're having problems with attention and focus. Your memory is short. You can't remember things. You have difficulty with decision-making and with judgment. Your speech and language gets affected. And your thinking, you're just slowed in every way in terms of your thinking processes. So how many of you know the name Phineas Cage? Does that ring a bell for you? Phineas Cage. He is one of the most famous individuals who experienced TBI, and he is the one who actually shone a light on neuroscience. So Phineas Cage was a young man, 25 years old, who lived in Vermont and was a foreman on a railroad crew. This was in like 1815. His job was to pack dynamite into a iron rod to blow up, things to place to create the railway line. So he had just packed his rod with dynamite, and somehow there was there was a problem with the timing, and it detonated while he still had it in his hand. And do you know what happened? That entire iron rod with the dynamite flew from his hand, entered his skull through the bottom left cheek, and shot through his skull and came out on the right side on the top of his skull. It actually shot out and fell out of his head. And what happened to him? Can you believe it? He survived that injury. He was rushed to the hospital then. He lost vision in the one eye, you know, where the rod went in. His speech, memory, and motor functioning stayed intact. But guess what changed? His personality and his emotions. He was a changed man. Everyone who had worked with him said, he is different. This is not the same Phineas we knew. He went from kind of a light-hearted, amiable guy to someone who was irritable, grumpy. He actually, it says he became an alcoholic. He was aggressive. This was a huge, I mean, a dramatic change in his personality. And it was then the first time that neuroscientists came to know that personality traits reside in those front of the brain, you know, in the frontal lobes, in what's now we know is the temporal lobe. Sadly, he couldn't go back to work on the railroad with the railroad crew as a foreman. He kind of wandered around trying to find, you know, something to do, you know, and eventually was ill and went to California to live with his mother and sister, where he died of a seizure disorder 12 years after his injury. So this is one of the most famous cases of traumatic brain injury. And this may sound a little macabre, but his brain, along with that rod, is at Harvard University. It is displayed in their neuroscience lab. So this, just to tell you what profound impact this injury had on Phineas Cage. Next slide. So it's not just the severity. Remember I said mild, moderate, severe. That's very critical. But what are some other factors which go into play? Cumulative effects from multiple TBIs. That means the number and our spacing. Are you getting hit every week? If you're in a sport where, you know, your head gets knocked, like in boxing. Do you know, there used to be a kind of dementia that boxers developed. It was called dementia pugilistica, which was basically that they were getting these blows to the head. So it is the number and the spacing. How quickly or how closely are they spaced? Age at injury. Remember I said that when you're younger, like a child or a preteen, it can affect your development. How recent? And is it combined with any other neurological conditions? And why am I telling you this? The next time you meet with your client who's exhibiting some kind of thing you're puzzled about, you think it's traumatic brain injury, or you may know it, ask these questions. Did they have multiple? How often? How were they spaced? What was the age at injury? How recent was this injury? Next slide. So we already talked earlier about the fingerprint of TBI, but I just want to emphasize it over and over again. Frontal areas of the brain, including the frontal lobes, you know, the one in red, are the most likely to be injured as a result of TBI, regardless of the point of impact to the head. And guess what? Executive function are located in those very same lobes. So that is the fingerprint of TBI. If there's one lesson you take back today, it is the fingerprint, frontal areas of the brain. Next slide. So why am I saying this? What is the significant brain behavior relationship? Look what the frontal lobe governs. Initiation, your ability to start a task. Problem solving. Judgment. Inhibition of impulse, like you all are doing it today. You know, it's a bright, sunny day. You gaming, or you may be thinking of wanting to go out, but guess what? You're inhibiting that impulse and sitting, you're on this Zoom meeting listening to me. That is, you're able to inhibit your impulse. People with brain injury cannot. Your ability to plan. You all did a lot of planning to be here today, right? You had to register. You had to figure out whether you could access Zoom. You had to take the time off from your program and supervisor. You had to put it in your calendar. You had to watch out for reminders. All of that was planning. We take it for granted, right? Self-monitoring. Hey, am I doing okay? Do I need to change something in my behavior? Organization. Mental flexibility, that you're nimbly able, or you're flexible, that you can change from one train of thought to another without having a meltdown. Your ability to concentrate. And then we talked already about personality and emotions, how Phineas was gravely impacted with that horrendous injury that he had. So this is the significance of that fingerprint injury, because this is what gets affected. And can you see how, in a way, it infects your entire life? Next slide. So what effect does this have on treatment? Which all of you in some way or the other are engaging with clients or consumers or individuals with TBI, whether you call them peers, whatever it is. What is the cause? Due to cognitive and behavioral impairments as a result of this damage to the frontal area of the brain. Remember the fingerprint injury? Individuals with a history of brain injury have difficulty with knowing what problems they have. It seems very obvious to you, but they have no idea what their problem is, or they don't have a clear handle on it or good insight into it. They have little ability to change their behavior. They have problems accessing services for all the reasons I just talked about. They have problems with organizing, with planning, with decision-making. Guess what? It impacts their ability to access services. And lastly, sadly, it impacts their ability to remain engaged in services and treatment. And I'm going to talk about why. So take a moment to let that sink in. This is what it results in for all of us who are on this phone today, on this Zoom conference today. Next slide. So what are the barriers? And some of them we have created it as providers. Lack of experienced staff and resources who understand how to adjust their approaches to help individuals with TBI. If your client comes 10 minutes late because he has a hard time organizing and planning and getting on the bus in time, how many of you turn them away? Hey, you missed your appointment. He's non-compliant. As opposed to, hey, you know what? I need to adjust my approach. If he's 10 minutes late, I can still see him. Maybe we need to be calling him more regularly about his appointment. So it's lack of experience and inability, or you have not adjusted your approach. Misinterpretation of symptoms of TBI by providers. All of those negative labeling and that bias, whether it can be both explicit and implicit. Lazy, non-compliant, difficult, challenging. Can you see the trend where the bias is? Because we are misinterpreting the symptoms. Lack of environments rich, I'm saying forget rich environments, just environments to provide stimulation, structure, and support to these individuals who've had some grave injury to their brain. And discontinuation of treatment before goals are met, either from the provider, he's not coming, he's dropped out, he's hard to engage, we give him 3 strikes, if he misses 3 appointments, we close the case. So discontinuation of treatment before goals are met, either by the provider or by the client. And why by the client? Because there's a mismatch between what his needs are and what you're offering him. So take a moment to think about this. Do a mental evaluation of your program and what you offer people with traumatic brain injury. Have you adjusted your approach? Next slide. So who are at risk for TBI? And I'm going to spend a few minutes so that all of you, and why am I wanting to identify populations who are at high risk? Because that should always alert you whenever you have a client who falls into one of those categories. And since this is really a behavioral health kind of training, so I'm going to focus a little bit on that population too. Next slide. You know, one of the biggest ones are athletes and people who play sports. And did you know that some of the most dangerous sports for head injuries are, guess what? Biking, skating, and skateboarding. And very sadly, one of our colleagues at where I work, her 18-year-old son, about to graduate from high school and head to college, was skateboarding in Salem, just, you know, with his friends, fell backwards, hit the pavement, and had a massive brain injury and died. So he was skateboarding. There are many other contact sports which put you at high risk. So sports injuries, very dangerous. You know, that's a population that you should be screening for if you know your client had been active in sports. Next slide. Veterans. 1 in 5 returning troops, that is 20%, have a brain injury. And 1 in 10 sustained a concussion or more than a concussion. So 20%, so that's very high. So if you're working with veterans, you can safely say that 1/5 of your caseload, you know, there's probably a traumatic brain injury, if not all, because they're seeking help. And why is this increase? Because of technological advances in the battlefield and in battlefield gear. It reduces death, increases severity of injuries to head and limbs. So that's why during the last 20 years, we have seen so many more of our military veterans survive horrendous injuries because of all the advancements. Modern military medicine allows for life-saving trauma care in the war zone with immediate transport to definitive care and rehabilitation. Next slide. And I've just given you some statistics here, and I'm not going to go over them for time. Needless to say, this is the signature injury of our current wars. Next slide. Did you know older adults are another big group that is susceptible and has a very high prevalence of traumatic brain injury? Because 1 in 3 older adults, that is age 65 and older, falls in Oregon. They have a fall in Oregon. Traumatic brain injury is a significant problem for older adults. In persons age 65 and older, TBI is responsible for more than 80,000 emergency department visits each year. And, you know, 3/4 of them result in hospitalization as a result of that injury. Adults age 75 and older have the highest rate of TBI-related hospitalization and deaths. And falls are the leading cause of TBI for older adults. And second to motor vehicle accidents. So all of you, I know there was a whole bunch of people from APD, behavioral health folks, nurses. If you're working with an older adult, ask about falls. Ask about falls, screen for falls risk. It's preventable because it is the leading cause of traumatic brain injury. Next slide. Falls, I said, are the leading cause of hip fractures and traumatic brain injury among Oregon seniors. It is also the leading cause of fatal and non-fatal injuries for adults 65 years and older. 1 in 3 older adults falls. And guess what? We are an aging society. Oregon is aging, especially Central Oregon. There are 2 counties there which already look like what Oregon will look like by 2030, which is you already have your population is 25% older adults. How many of you routinely screen for falls and falls prevention? While falling is common among people of all ages, the severity of injury for older adults can result in loss of mobility, independence, and death. And it can exacerbate any early dementia when you hit your head. Next slide. Look at traumatic brain injury and mental health and substance use disorder. Many of you work with them. I saw when we did our little poll. TBI is common among people with co-occurring mental health and substance use problems. Repeated and serious TBIs are common in this population. Failure to detect TBI by us, by all of us providers, with co-occurring disorders who are seeking integrated treatment could lead to misdiagnosis and inappropriately targeted treatment and rehabilitation. So they looked at a study, and what they found was that 80% of this group screened positive for TBI. That's high, 80%. And 25% reported at least 1 moderate or severe TBI. Remember, that means 30 minutes or more of loss of consciousness with abnormal CT or MRI scan. That's high. That means a quarter of those 80%. TBI was also associated with current alcohol use and severe psychiatric symptoms. And with, guess what? Lifetime institutionalization and homelessness. It was obviously more common among participants with post-traumatic stress disorder, antisocial and borderline personality disorder, and men versus women. It was more common. Next slide. Look at forensic population, brain injury in our forensic psychiatric patients. And you know, in Oregon, we are facing a crisis in people with mental illness who are being adjudicated, and sent to either prison, which is our new psychiatric hospitals, or they're sent to a state hospital for evaluation. So it's a big population, the forensic population, psychiatric forensic. History of TBI was ascertained in almost a quarter of patients. They looked at patient records in this study. So almost 1/4 of them had a TBI. Compared to those without a documented history of TBI, persons with a history were less likely to be diagnosed with schizophrenia, more likely to be diagnosed with alcohol and substance use disorder. And there were also differences observed in respect to the offenses. So what is the conclusion for all of you behavioral health providers here, whether you work in patient psychiatric or state hospital or in a primary care clinic? This study provides evidence to support routine screening for a history of TBI in forensic patients. Next slide. Homelessness and TBI. So they did this, Lancet is a British publication, and they did they did a systematic review, and they did what we call a meta-analysis of many studies over the course of like 25 years. And what they concluded was from these studies, homeless people experience a disproportionately high lifetime prevalence of TBI. Look at the results. 1 in 2 homeless people, that is 50%. In this study, it was 53%. And 1 in 4, and almost 1 in 4. So 1 in 2 half experience a TBI, and 1 in 4, that means a quarter of them had moderate to severe TBI, and they were homeless. And maybe the homelessness was because of the TBI. The authors call for all of us workers who touch people who are homeless in whatever capacity, whether you are social services capacity, safety net capacity, or you have a mental health program and you're doing outreach, to have increased awareness of the burden and associated effects of TBI in people who are homeless. Noting that more comprehensive assessments of their health, including checking for TBI, may improve their care, may help them remain housed, may help you wrap around services if you know what kind of accommodations you need to make. So for all of you who work with homeless clients, remember, just take it for granted that half of them will have a TBI, and a quarter of them will actually have moderate to severe. That means they have quite severe brain dysfunction. Next slide. What about COVID-19 and traumatic brain injury? You know, COVID-19 has really revealed some very deep fault lines in disparities, whether it is racial, ethnic, or disability related, which is a sad commentary, but true. And the reason why I'm bringing it up is maybe we need to be working on seeing how can we mitigate those disparities. Look at people with traumatic brain injury have higher rates of exposure to the virus. Why? Because they live in lower socioeconomic communities. They live in congregate living, whether it's institutional or we've put them in some kind of a residential care facility, or they are in jails, prisons, and nursing homes. They have greater vulnerability to this illness because of poor or pre-existing poor health and chronic conditions. Often they are neglected. There's a poor integration of health. So they are greater vulnerability. And lastly, what are some of these shutdown related issues, such as social isolation and stay at home? You know, someone told me, someone with brain injury and also people with serious mental illness, welcome to my world. I am alone all the time. I don't have friends. I live in social isolation and loneliness. I'm rejected and excluded. So welcome to my world. So that's what COVID-19 has done in terms of exposing the disparities. Next slide. So, I always get this question, hey, Nirmala, what's the difference between traumatic brain injury and acquired brain injury? And I'm sure some of you are asking that question. And I want to just briefly let you know what the difference is. Traumatic brain injury refers to injuries to the brain, which we talked about, are the result of a mechanical force. So some outside force is hitting your head. Falls, motor vehicle accidents, assaults, falling objects, a rod going through your skull, like Phineas. They all can cause traumatic brain injury. Acquired brain injury is a more general term that refers to any acquired, not developmental, okay, not neurodevelopmental that you're born with. So you have to acquire it. So it's any acquired injury to the brain tissue. And guess what? Traumatic brain injury is one such acquired brain injury. However, not all acquired brain injuries are considered traumatic brain injury. So we're going to look at that. Next slide. So what are acquired brain injury? Strokes, which have the same effect. They affect your brain. Bleeding in the brain, which could result in hemorrhage, hematoma, putting pressure on your brain. Lack of oxygen to the brain, which could be, through near drowning. It could be your heart stopped because you were having a cardiac arrest. You had a drug overdose and it took a while for someone to administer an naloxone or whatever. And so your brain was deprived of oxygen. Infections to the brain. It could be toxic exposure to some substance. It could be carbon monoxide. You're inhaling toxin chemicals like solvent sniffing, and excessive and prolonged use of drugs and alcohol. Fluid buildup in the brain, and then brain tumors like cancer and other maybe benign tumors, but they also affect function. That is what acquired is. Can you see? It is not an outside mechanical force hitting your head, causing the traumatic brain injury. It is something happening internally. So I just wanted to clarify that for everyone. However, the effects can be the same in terms of its cognitive and executive function impact. Next slide. Can to the next slide. So I just want to briefly go over what are some, and I'd like you to equal, which is kind of so effects of senses, so sensory. So you can get headache, post dizziness, blood. Could we just go? Sorry, folks, we are getting back on.
It looks like it. I know that we had some issues with the audio.
While we're doing that,
you're coming in strong on my end. Hopefully we can get some feedback from our participants. If one or two of you would write in and let us know.
I can't, my computer is frozen.
Okay, so you might want to go off video for right now.
Did something happen?
I think it's your connection, because we've got your slides up and you have been spotty with audio, but audience says that you're coming back on more clear. So maybe what we do is we cut the visual feed for you for right now and we go strictly with audio and the PowerPoint. How does that sound? Okay, am I talking to myself? No.
Okay. Can we just go one slide back? If you're having problems, that's okay.
I think it's the internet connection on
your end.
Are you hearing me,
Hello,
Nirmala?
Can you hear me?
Yes.
Okay. So I'm just talking about, what are some of the consequences, and you can see them, it affects all of these areas, light sensitivity, smell, taste, poor coordination, slurred speech. Next slide, please. I think we missed one. Yes. And cognitive, which is what I want to focus on, is attention and concentration can get affected, memory, language, slowed information processing, problem solving, decreased ability to initiate tasks or work, which we call executive functions. Next slide. So why are we having this training today? Why did Angela think this was a good training to give to all of you today? because part of our initiative wants to really develop a workforce that has the knowledge and skills to better work with older adults with behavioral health issues and with other populations, disability populations. And that is why we are doing this training today. So my goal is for all of you today, how to elicit and evaluate a person's history of brain injury in your workplace, how to recognize and accommodate cognitive and executive function impairments in your practice. So these are the new skills I want to teach today. Next slide. Why is screening for brain injury important? I've been kind of weaving that message throughout. TBI is not usually a visible diagnosis. Someone doesn't come into your office wearing a t-shirt that I have TBI, or it's not visible to you. Some individuals may not know they've had a TBI. Documentation history of TBI may not be found in the medical records because remember, all along we are calling it an invisible injury. We want to change that language and make it a visible injury. So this is why it is important to screen. Next slide. Questions that you can ask during your intake or your first interview, whatever you call it, when you first see the person, or maybe down the line now that you know what you need to do. Have you ever been hospitalized or treated in an emergency room following a head or neck injury? Have you ever been knocked out or unconscious following an accident or an injury? Have you ever injured your head or your neck in a car accident or some other moving vehicle accident, like a motorbike or something? Have you ever injured your head or neck in a fight or a fall? A yes answer to any of these questions indicates that you should do a more formal TBI assessment. Okay? So my hope is, remember first I said take-home message was the fingerprint of TBI. Second message was how do you decipher the continuum of severity? Now third would be I need to screen, and this would be some questions that you can incorporate very easily into your interview. Next slide. How do you identify someone with brain injury? Knowing a history of traumatic brain injury can help all of you, professionals and paraprofessionals, provide effective treatment for your patients and clients. And this is one of the very good screening tools that I'm recommending, the Ohio State University Traumatic Brain Injury Identification Method. By the way, it was actually developed and it's used widely. It is a standardized, short, structured interview designed to elicit a rich lifetime TBI history. We are not going to go over it today for lack of time. However, you will be receiving this instrument in the documents that Angela will upload in EATS. And in your resource list, which is very comprehensive, there is also a video training of how to use this. So any of you who are considering, hey, I want to take this back to my workplace and talk about it, you will have the resources. Alternatively, you can let Angela know through the chat box, hey, we would like a follow-up training on some of these subjects. But I would highly urge you to take a look at this instrument. Next slide. So I'm going to now shift gears. What we are going to look at, what are the symptoms of TBI, and if they fall into these categories: emotional, behavioral, physical, cognitive, and social. And I'm going to really focus more on the behavioral cognitive portion of it. Next slide. So emotional are anything from depression, anxiety, reduced confidence, apathy, just feeling numb, intense fear, fear about the future. And it can be on a continuum of severity. Next slide. Behavioral, anger, poor frustration tolerance, very confrontational and belligerent behaviors with others. We already talked about impulsivity and impatience, withdrawal. All that is behavioral. Next slide. Physical, we've gone over some of them, headaches, pain, fatigue, changes in vision and hearing, other changes in your senses like touch, smell, and taste. Next slide. And again, sleep, changes in appetite, vertigo or dizziness, motor, coordination and motor speed. Next slide. Cognitive, changes in attention, diminished memory or impaired memory, slowed speed of mental processing, kind of being in a state of confusion, disorientation. You don't know where you are, what you're doing, what day of the week it is, you're lost. Changes in decision making, marked changes in judgment. Remember, those were some of the changes that people saw in Phineas Cage. Changes in ability to plan and organize and self-regulate. Next slide. And then there are social changes, changes in your relationships, where your spouse, partner, or family cannot understand who is this new person? What's wrong with him? He's always screaming, yelling, and is belligerent. It can affect relationships with children, if you have children. Changed ability to engage in hobbies and leisure activities. Decreased ability to work or perform in school. Feeling isolated and lonely because people don't understand you. Or the family feels isolated and lonely because nobody understands what they're going through. Which leads to what? Increased alienation from others. Hey, nobody understands me, or nobody understands what we are going through. Next slide. And then there are also those, what we call psychiatric comorbidities. That means psychiatric illnesses that often come or accompany a head injury, depression, suicide, PTSD, substance use, and opioid use disorder. And with our veterans, that's very, very pronounced. And unfortunately, because of lack of time, I am not going to be talking about psychiatric comorbidities. If you would like a training on that, please put it in the chat box for Angela. Next slide. So again, just a refresher on mild brain injury. Remember, no loss of consciousness or less than 30 minutes. Generally, it is, the person is a little bit dazed, and it's a normal neurological exam or MRI or CT scan. Next slide. And here are some mild effects. Some slurred speech, some headaches, disorientation, foggy memory, delayed response to some questions. And of course, effects of repeated concussions are cumulative. And then ringing in the brain, ears. Next slide. Symptoms may not appear until later. We call this post-concussive syndrome, which can include those headaches. I told you about my friend who had the car accident. He didn't experience it till next day. And the symptoms improve within 1 to 3 months. Next slide. In moderate brain injury, results in loss of consciousness, I told you, that lasts 30 minutes or more. And it's followed by a few days or weeks of confusion and abnormal CT and MRI. Next slide. Severe almost always results in prolonged unconsciousness or coma lasting days, week, or longer. And I know very often I consult on complex cases where someone provider is telling me, yes, he has brain injury. And I ask them, Do you know what caused the brain injury? Was he ever in a coma lasting these? And most people don't know what to tell me. It is so important to get a good history, because that really tells you how best you need to accommodate your services to meet this person's need. Next slide. So this is not for you all to master. I just wanted to give you the information that what is the Glasgow coma scale. It is a system for, this is a gold standard system for assessing the degree of impairment in consciousness in a critically ill person, where the medical team is trying to identify the seriousness of their illness. And it involves 3 sets of questions, or what they call determinants: eye-opening, verbal response, and motor response, all of which are evaluated. Why eye-opening response? If the person can respond to the stimuli by their eyes, that means your cerebral cortex is intact. If you don't, then it's not intact. And for motor and verbal, if you are able to respond, that means your central nervous system still is fairly well integrated. But just rule of thumb, that the lower your score, the more severe your injury. Okay? So, so for someone who has mild TBI, and it's short form called GCS, the score is between 13 and 15. For moderate, it would be between 9 and 12. And for severe, it would be 8 and lower. So basically, if you have a lower score, that means your injury is more severe. So the next time you get a medical record, look for the Glasgow coma scale. If you know your patient or your client was in a rehab center or an ER trauma center, what was his Glasgow coma scale? Next slide. And I'm just giving you what the 3 sets of questions are. And it's basically a algorithm where they calculate all of the scores depending on their response and come up with those scores I was just telling you, that if you score 13 and 15, for example, if you have mild and you are able to open your eyes spontaneously, you would get a 4. So based on that, they give you the level of severity. Next slide. And this is just a nice, I just found this interesting. And so I put this here for you to better understand the scale. But for why I'm giving it to you is for you to have knowledge about the Glasgow coma scale so that you can ask about it. And if you read it in a medical chart, you will be able to interpret the score. Next slide. The other one is called the Rancho. Rancho Los Amigos scale was developed at this hospital in California. The scale is used by therapists and families to help understand behavior and progression of the head injury survivor as he goes through rehab. So this scale is actually used in rehabilitation. The Glasgow scale is actually used at the time of the injury in the ER or in the trauma center or someplace. This is for rehab. And again, this is for your information. So the next time someone tells you, hey, he has a Rancho score of this, you will know what they're referring to. So it's rehabilitation. Next slide. And this is it's generally expressed in a level, Hey, his Rancho is level 5, that he's confused and inappropriate. Or level 6 would be he's confused, but his behavior is appropriate. So for you to understand this, I have included this, but it's a whole different training to fully understand it. This was really just to give you knowledge about these tools and scales. Next slide. So again, my picture of the lobes. Now you should know this by heart. The fingerprint of TBI is frontal lobe and the temporal lobe. That's where most of the injuries happen. Next slide. So what are the cognitive changes? We call those executive functioning, goal setting, self-monitoring, planning, impulse control, modifying or being flexible, initiating tasks and completing tasks. These are some of the things which are controlled by this executive in your brain, which is the frontal lobe. In fact, executive function is called the CEO of your brain, the chief executive officer. Next slide. And these are a combination of emotional and behavioral changes. Again, I don't want to go over them, but you can see decreased frustration, impaired judgment, disinhibition, changed personality, aggressive behaviors, emotional ability, you're going from highs and lows, everything in between. Next slide. And what are the psychosocial changes? We talked about family issues. We talked about how it can impact your work and education, interpersonal difficulties with significant others and children, intrapersonal difficulties. So lots of psychosocial changes too, which need to be addressed. Next slide. So I really want to focus on this. What are the cognitive consequences? Difficulty with attention and concentration. Difficulty with what we call information processing. That means how fast you can process information and how efficiently you can make changes based on that information processing. Guess what? Much of our treatment and our interaction with people with TBI is what? Verbal. How many of you talk fast? Give them multiple tasks, put them in a group setting where they have to sit and learn about alcohol and drug information, when they are having information processing problems, where they are having learning memory problems, especially memory problems where you have to retrieve information you've learned, new information. Reasoning, problem solving, sequencing. How do I put my medications in the right order? Insight, planning. Next slide. So remember I said executive functions are the CEO, chief executive officer in your brain. It has also been likened to our air traffic control tower. Having executive function in your brain is like having an air traffic control system at a busy airport to manage the arrivals and departures of dozens of planes on multiple runways. That's what executive functions do for all of us. It is kind of the hub which manages all of these, multiple cognitive tasks, domains, and functions that come naturally to all of us. We don't even blink an eyelid to think about it. But when you're impaired, it's a struggle. Next slide. So what are executive functions? Completing most tasks requires successful orchestration of several types of executive functions. And here I've given you a picture of an orchestra. They all have a part to play. That's exactly what executive functions do. Next slide. So it is an umbrella term. Again, I'm repeating myself, but I want you to kind of learn this by heart. This is what executive functions are. And this is what gets affected in TBI. Remember, the fingerprint of TBI is it affects your frontal lobe, the front of your head, the front of your brain. All of these get affected. Can you imagine if your social behavior, your ability to monitor your social behavior is gone, what you will be doing? You'll be intrusive, you may be aggressive, you may disrobe, you may inappropriately touch people, or you are unable to inhibit inappropriate behavior. It just comes out, there's no brakes, you can't put the brakes. You can't make decisions. You vacillate, you worry, you spend hours, changing your decision because you can't make them. You can't problem solve even simple things. And we as a provider then label them. They are not working hard enough. Next slide. So I'm giving you an example of what executive function in action looks like. Take a simple task like cooking a meal, which we all do, or some of us maybe not as often as others, but cooking a meal. First of all, you need motivation or drive, which is an executive function. You want to make a nice meal, and then you make that decision to start doing it. Decision making. Planning and organization. You have to have a budget. You have to get the ingredients. You have to decide on the right time to start cooking so that it'll be ready by a certain time. So can you see what all goes into it? Much more. I've just put a few things there. You have to monitor the performance. You have to check to see if the food is cooking properly. Flexible thinking. You may have to lower the heat if the food is overcooking, or it's cooking too quickly, or it is undercooked. Multitasking. You may be washing laundry and drying it while you're remembering to attend to the food at the right times. So can't you see how complex it is? But none of us, all of us on this phone call today, hardly ever think, oh my gosh, now I'm motivated to cook and now I'm planning and organizing. It just comes naturally to us. But now think of your client with significant brain trauma. Can they do this? This is what executive action looks like in real life. Next slide. So here are the cognitive impacts of brain injury. Difficulty with initiating, organizing, and carrying out activities. So what would it look like? Loss of get up and go. Often mistaken for laziness or lack of motive. He's just lazy, he does nothing. Problem with thinking ahead and carrying out the sequence of steps needed to complete that task. Second, rigidity in thoughts and actions. Remember, you're not flexible once your brain is damaged. You can't shift easily. Difficulty in evaluating results of actions and reduced ability to change behavior based on that evaluation. You know, by me yelling at this person, it's not helping. Maybe I need to change my approach and talk more softly and more politely. They're unable to do that. Poor problem solving, finding it hard to anticipate consequences. You know, it's impulse. I'm just going to do this without thought about what would be the impact, what would be the consequences. Decreased ability to make accurate judgment or find solutions if things go wrong. Hey, I got on the wrong bus and I'm lost. You know, I should have taken this bus instead to get to my destination. Nope, they don't have that ability to problem solve in real time. Impulsivity, acting too quickly without fully thinking through the consequences. They no longer have that filter or that break that I need to stop and think and then act. It just happens as soon as it comes to the fore. How many of you know of clients who have gotten into serious trouble because of impulsivity? One of the most sad cases I ever had to do an assessment on, and many of you may know of this, is a gold medal Olympian skier who used to live in Oregon, actually in Clackamas County. And in 2002, while training for the Olympics, he was an alpine skier, suffered a major head trauma, an accident skiing, and it totally changed his life. It was all of his frontal lobe. He could no longer compete. He had no judgment, no memory. He was constantly picked up by police for inappropriate behaviors or driving too fast. And I still remember when the police would stop him, he would pull out his gold medal and show them his Olympic gold medal, but couldn't understand why they had pulled him over. His mother had to take care of him. Eventually, he was mandated to come for an assessment. That's how I met him. And it was very sad. He had severe brain trauma secondary to the Olympic ski accident he had. Subsequently, it was very difficult. He eventually died at a very, about 15 years after his accident. But I still remember this person so clearly, the impulsivity, the poor problem solving, the difficulty in social situations, reduced ability to engage in social interactions, hard to find it hard to engage and initiate conversations, or they say inappropriate things. And what happens then in social circles? People shun you, they walk away. It can also maybe entice an argument or a fight. And difficulty with memory and attention is hard to concentrate. Difficulty learning new information, decreased memory for past or current events. And what do? We put them in group settings for, say, alcohol and drug treatment, where they have to, remember things. When their memory is short, they can't learn new things. They can't remember and retrieve that knowledge. Next slide. So again, I'm just highlighting the problems. Next slide. So the communication problems which are language problems, because your brain is affected, trouble finding words, difficulty understanding written and verbal communication, difficulty with writing and spelling and syntax, like with grammar, all changed after the head trauma. Next slide. And can you imagine what impact this has if you're in school or college, or you're working? Or it could be you're interrupting conversations, inability to follow a conversation because you're having language difficulties, unable to process nuances of language. When someone is serious, or when it's tongue-in-cheek, or when it's a metaphor, everything is literal. So can you imagine someone struggling with this? What do you think would be the end result? Frustration, correct? And with frustration, they could fly off the handle. You can't understand me. I'm trying to tell you this. Next slide. This is a very common problem, and I'm putting it first because so many people don't understand it. What we call decreased initiation or task initiation. This is a brain function, an executive brain function. Example, providers tell me, he just sits watching TV all day, staring at the TV. He does not bathe or brush his teeth unless I remind him. And you know what? He's been here 1 year. He's lazy. He knows what needs to be done, but does not get started. He just sits there. He's lazy. He does not think of ideas for social activities. And if I don't help him with that, he won't come up with anything. This is really an executive function problem, and we call it decreased initiation. It is not laziness. It is not being uncooperative. Next slide. Problem solving. Your client makes quick decisions without thinking about the consequences, what will happen. Or they get stuck between different choices and they're unable to pick between them, especially when you are giving them 5 choices and their brain is unable to process it. They get stuck. And what gets happened, they get frustrated and you get frustrated. And it's easy to label them as, hey, they don't want to work with me. They are uncooperative. I'm doing all of this for them and they're still not working with me. It is because they are stuck and they're unable to kind of weigh the pros and the cons of these multiple choices. They get stuck on one idea and they're unable to consider ideas. So it's kind of like that tunnel vision. They're focused on just one idea, one solution. And here you're giving them a smorgasbord of solutions, expecting them to choose, and they're unable to. And it frustrates you. It frustrates you maybe as a provider or as a residential foster home provider. And or they approach a problem that makes no sense to you. So these are some of the real life problem solving difficulties. Next slide. Slowed processing speed. It takes longer for them to answer questions. It takes longer to understand things. He or she understood very easily before. Takes a longer time to react to things. And this could be dangerous really in emergency situations, like when there's a fire in the house, you have to get up and run, or when you're driving where you have split second to make decisions. And that is one reason why we limit driving for people with brain injury and or actually with dementia because of slowed processing speed. So can't you imagine when you are barking away commands, giving them a ton of information at a very fast pace because you have only a 30-minute appointment and the person has only caught the first 3 words of your sentence because it is the entire processing speed is slowed down. They don't understand what you're saying. They can't comprehend what you're saying, and they leave your appointment unable to follow whatever you've asked them to do. Next slide. Memory is impaired. They forget appointments, they forget names, they need to have things repeated many times, they take longer to learn new information, if at all. They forget things very easily, frequently lose or misplace things, including medications and appointment cards. And they may repeat questions or the same story over and over again. Can you imagine how frustrating it is? Can you imagine how you as a provider, do you acknowledge memory problems? How do you accommodate for forgetting appointments? How do you accommodate for him or her taking longer to learn new information? Next slide. Attention. You know, you need attention to learn new things. So attention and memory go together. So if I am teaching you some skill and you don't have attention and your mind is wandering, what do you think is going to happen? You already have some memory impairment, but when you're not even able to concentrate or pay attention, even whatever little bit you have goes out the window. That's what ADHD and all is really, it is attention. They have trouble focusing, staying on task. You know, he wanders, his mind wanders, he never finishes what he starts. Easily distracted by noise or visual stimuli, whether it's lights, TV, music, whatever it is. Trouble concentrating while reading. You're giving him, something to read in a class, or asking him to fill out a long intake form, admission form. Difficulty doing more than one thing at a time. Difficulty switching gears or changing focus. And missing key pieces of information in the conversation or in the class that you've sent him to, because he or she is unable to focus and have that level of attention. So can you see how all of this impacts the life of our clients? And how important it is for us to have knowledge and awareness about this, and then accommodate our programs and our interventions accordingly. Next slide. So how can you help? What are some lessons? And these are just 4 things that came up to my mind: structured, consistent, repetitive, and meaningful. But let's unpack that. Next slide. So when your client is having trouble engaging in or benefiting from any of your interventions, whether it is an intake you're trying to, or you're connecting him to some appointments or to housing, ask yourself these 2 important questions. Could this be related to a neurological problem? And what can I do to accommodate? Instead of jumping to conclusions, which all of us are guilty of, let me tell you, he's a difficult patient, he's challenging, he's uncooperative, or what do we call it, non-compliant, he is lazy. Ask, is this related to a neurological problem? And what should I be doing? Remember, you have the brain that is intact, not your client. What can you do to accommodate? So this is the other take-home message for all of you who are actually providing services. The next time you are feeling frustrated or stuck or stymied or just frustrated working with a client, ask these two questions and see what answers you get. Next slide. What does it mean to accommodate? That means simply provide services in a manner that takes into consideration the special needs of that individual. In our case, in our training today, that he has brain dysfunction. He has executive function problems. Provide accommodation creates an opportunity to address barriers to treatment success. And disability rights are civil rights. That's why the United States Congress passed the American with Disabilities Act. You know, sometimes we accommodate for vision and hearing loss, but I think we are less open to accommodating for brain injury loss, you know, where your brain is affected, because all along we are calling it an invisible injury. So remember, disability rights are civil rights. That means they are guaranteed to you by the US Constitution. Next slide. So what should I treat first? Treatment should first address the symptoms that are causing the person the most distress. So help with symptom management, whether it is physical, mental, whatever it is, work with that. Target symptoms that immediately affect daily functioning and quality of life. And very important, build hope and self-efficacy. Self-efficacy simply means building confidence in that person, confidence that he or she can succeed, he or she can take care of himself. Next slide. So treat what you know. Pre-existing psychiatric and substance use disorder, make those appropriate referrals or assessments and referrals. And remember, don't just give it, don't just verbally say, hey, go there for your appointment. Learn what you need to do to make sure that they keep their appointment. Comorbid behavioral health, other conditions such as PTSD, depression, and then the symptoms that are interfering with their ability to function, like headaches, pain, and insomnia. So first try to work on all of that. Next slide. Don't forget, brain injury has a massive emotional impact too. It changes everything that a person relied on to define himself or herself. And they lose those abilities and attributes. Can you imagine? In addition, plans and dreams that the individuals have had are altered forever. And I go back to thinking about the Olympic gold medal skier that I attended an assessment on. You know, that was who he was, a gold medal Olympian in alpine skiing. And by the way, it was the first time when a country which was not their specialty ever won a gold medal. So it was a huge achievement. He lost all of that. He lost the dreams of ever being able to skiing again. So take that into account. Next slide. Give a consistent treatment message. Not you're messed up, you have all of these problems, you need all these services. And I know none of us do it. I'm maybe being a bit hyperbolic here. What you need to be saying is, you can do it and we can help you. That is that building that self-efficacy I spoke about. Promote realistic and positive expectations. How long did it take you to get to this point? You know, so build realistic expectations. How long will it take realistically to reconstruct your life? It won't happen in a week or two. So give positive treatment messages and build hope. Next slide. Accommodate cognitive impairment or executive function impairment. No two injuries are alike. It isn't only the injury, but the person who has been injured. So you need to take the whole person into account. Change the way the service is delivered. Change the way you deliver your service. Remember, we talked about accommodation, so that it reduces the impact of cognitive impairment. That is your goal. And how do we do it? We call that reducing cognitive load and encouraging cognitive compensation. So learn these two phrases: reduce cognitive load, encourage cognitive compensation. And so what is this? What is cognitive load? Next slide. Have you, all of you in the audience, have you ever been at a course where the trainer went through the material so quickly that you barely learned a thing? Or maybe the content was so complex that it went completely over your head? I'm sure all of us have had that experience. Well, guess what? That is cognitive load, and that is the daily experience of people with serious, with traumatic brain injury. Next slide. This is what it looks like. Incoming information, whether it's at a training like ours, you have to keep it active in your head, then you store it in long-term memory, and then you retrieve it and use it. When you have dysfunction, this is all scrambled. And what happens when you talk very quickly, where you don't give time for slowed processing speed, where you don't accommodate for memory and attention, it is a huge cognitive load. And what happens is the person has learned nothing. Next slide. So here are some strategies we are going to spend quickly. Decreased memory, repetition, and note-taking. Teaching your client or consumer to take notes, write down everything. Sometimes now we can record it on your smartphones. But I would say note-taking is really important, keeping a diary next to them at all times. Decreased initiation. Remember, they don't get up and start a task. They're lazy. Put a schedule in front of them and remind them. Use alarms, whatever it takes to remind them and help them initiate. Decreased concentration. Give them cues or take breaks when the load is too much, cognitive load is too much. Decreased planning. Help them prioritize, review tasks, create a priority list for them. Remember, you have the intact brain, not your client. Forgets appointment. Instead of calling them non-compliant, send reminder calls. Give them a calendar, put it in their smartphone, write it, give it to the care provider to remind them. Poor follow through. They don't follow through on anything I tell them. They don't follow and do homework. Check in. Telephone and ask, are you practicing what we talked about? Do you need a reminder? Can I coach you on the phone? Or train your caregiver and coach so that she can coach you? Appointments, navigating, these systems of care are so daunting for us with intact brains. Can you imagine someone who does not have his brain functioning optimally, navigating systems? Accompany them to appointments. Ask them to write a list of questions and issues to be discussed. Next slide. Initiation. Individuals with TBI have difficulty getting started on things. Provide prompts. Help cue your client to begin and end a task. For example, if they need to shower every day at 8 a.m. and they live in a residential setting, go to their room with a towel on your arm, which is a cue, and tell them, hey, it's time to shower. Once they get that cue, they are able to complete the task. Develop a queuing system that will work to help your client follow through on tasks. Next slide. Understand that this problem is due to brain injury and not laziness, and not due to lack of motivation or non-compliance. Teach this to your care providers. Help your client come up with social activities. You may have to choose for them first, then make it a part of their routine so that it becomes a habit. Help them with checklists for the set of activities to help them initiate and plan for them. I'm just giving you some ideas here. Next slide. Memory problems. Always give a written summary of information that you have presented to your client. That is a best practice, so that they can read it later at their own pace and understand it. Always give it in writing. Be sure to have written instructions for anything that you're requesting them for future appointments or responsibilities or a skill. Always give it in writing. And write it simply and in plain English. Remind your client of appointments the day before and the morning of the appointment. Remember, they have a memory problem. Next slide. Attention. Schedule shorter sessions instead of long sessions. And guess what? Our group sessions are 1.5 hour long. How can someone with attention problems sit for that long? Limit the sources of distraction. If it's light, if it's noise, it's music, limit it. Use short sentences and express only one idea at a time. Ask questions and prompt the client to attend. John, can you listen? Can you turn back here? I'm giving you some information. That would be a gentle prompt to your client. Next slide. Slowed processing speed. Use short sentences. Express only one idea or give them only one task at a time. Encourage only one speaker to speak. Can you see, if they're in a group session, group therapy, how horrendous it would be for someone to keep track of 5 people talking? It is a total mismatch. Use patience. And this is something we have to teach our caregivers and our family members. Repeat information as necessary and always provide written summary. Next slide. Keep it simple for processing speed. It is easy for someone with processing speed to get lost in the conversation. So just make it simple. Check in frequently by asking, did you get what I'm saying? Did you understand? Can you repeat back what I said? Could you tell me what we just discussed? Slow it down. Make sure to provide sufficient time for the person to process it and respond. Can you see now the mismatch we often have in our treatment interventions and strategies? Next slide. These are some other coping strategies aside from what I just said. Teaching them problem solving. And there's a very structured approach. Teaching them to recognize and change their maladaptive thinking, which comes out of cognitive behavioral therapy. Teaching them relaxation training, pleasant event scheduling, seeking social support. And some therapies which are good are DBT, dialectical behavior therapy, which are really skill building therapies, and behavioral activation, where it promotes really helping clients to schedule pleasant events. Next slide. So what is my take-home message for all of you, wherever you work, whatever setting you work, whatever capacity you work in? Routine screening for brain injury and other sources of cognitive impairment. Learn to recognize when behaviors are a result of a neurological challenge, especially an executive function challenge. Remember, you have the intact brain, not the person with traumatic brain injury. Very important, make necessary program accommodations. This is a civil right, especially if you're a public program. View complexity as a rule and develop programming accordingly. Care plans should always include some kind of long-term wraparound supports for this person. Next slide. These are the resources I have used for my presentation today. However, you're going to receive a separate document which will be uploaded in EADS, which has some of the most wonderful resources you can imagine, including videos that you can download and take for a training. Next slide. I thank you so much for being patient with us today for some of our technology issues, but thank you to Kelly and Angela for doing a superlative job with Zoom technology. I hope I have in some way inspired you and given you some tools to work with your clients who may have frustrated you in the past because of your lack of knowledge and experience. And I'd like to end with this this little saying I have at the bottom of this slide, which I have used a lot with caregivers of all kinds, family and paid caregivers. Assume they're doing their very best. Thank you. And Angela and Kelly, we have a few minutes for comments or questions.
Yes, we do. And thanks again, Nirmala. We understand that some of you may need to move on to your next appointment or meeting. However, if you can stay with us, I think you'll find it highly enlightening. We do have a couple of questions. The first one is from Michelle Adams. Do cognitive consequences of TBIs ever get worse over the years, or do the consequences stabilize after a certain amount of time?
So yeah, very good question. So TBI is not like a dementia, which is a progressive illness. So TBIs do stabilize over time, whatever the injury is. So that becomes like your new baseline. So if it's severe and you have a severe impact on your cognitive issues, it will probably remain stable. It'll continue to be stable. It won't get worse. However, head injuries put you at high risk for dementia. So over time, you can develop a dementia over and above your TBI. And dementia is different in the sense that it is progressive and it is a continuous death of brain cells which are not renewed. At that time, it can worsen. So I hope I answered your question.
There we go. Rena Francisco has a case scenario that it sounds like we need to put you and the Lane County behavioral health specialist together with Rena. She's looking for somebody that can help advocate for one of her TBI clients in Lane County. So Rena, we're going to take that one offline because that one has so much to unpack, but I will definitely send you info to hooking up with the Lane County behavioral health specialist. Moving on, we have a question about can a TBI be the onset of voice hearing experiences?
And yes, I did not cover the psychiatric comorbidity piece. Yes, sometimes you can develop psychosis, which includes hearing voices. So yes, depending on part, where you're injured, complex, yes, but yes.
Okay. Susan Rounds asks, would brain injuries show up on the brain scans right away after an injury or later? She has a family member that was attacked and hit in the head with a bat, but the scans are showing no brain injury according to the family member. So there's some things to unpack there.
Again, I said if your injury is moderate to severe, which, you know, that's the criteria, is the loss of consciousness. One of the markers is abnormal CT scans or MRIs. So if your loved one is not showing an abnormal CT scan or MRI, it's probably considered mild.
Okay. Question about hypersexuality and TBIs. Is this about impulse control, pleasure seeking, or both? Do you find hypersexual behaviors with traumatic brain injury?
Absolutely. It's an executive function. Impulse control, inhibition, those are all executive functions. And remember, the fingerprint injury of TBI is your frontal lobe. So yes, disinhibition, sexual acting out, inappropriate social acting out are all a sequelae of TBI.
Okay. So somebody that might be heavily into pornography might be one of the issues that they're dealing with subsequent to a head injury.
You know, I think in terms of pornography, I don't know the situation. We sometimes have double standards. There are lots of people with no head injury or heavy into pornography. It's a culturally accepted thing. I'm not advocating for it, but I would not comment on that right now
Okay.
because I had lots of issues with providers who label, I work with serious mental illness where someone with serious mental illness living in a residential setting was banned from pornography while their son of the provider could watch. So I don't know what the situation.
Got it.
So I wouldn't say just watching pornography is a symptom of a head injury.
Okay. So this might be an easier question. Can dyslexia be a consequence of a head injury, or is that from a different brain center?
It all depends on, did it begin right after the head injury or did they have it before the head injury? If it happened right after, yes, language, written, verbal, all of it gets affected. However, if they had dyslexia before, then it's not a function of the brain injury. It can maybe get worse, but it wouldn't be symptomatic of the brain injury. But language and communication does get affected.
Thank you. Paranoia or a high level of suspiciousness of systems. Could that be a consequence of traumatic brain injury? Or that one's again a hard one to unpack. Maybe we need to save that one for your psychiatric comorbidities training.
I'm going to say that, yes, it is part of psychiatric comorbidities. And also systems. I would be paranoid about systems if they're not very helpful to me.
Okay, so now what I'd like to ask, Kelly, can you please put up the revolving slides that once again give the code to get into EADS. It's 14 news, for those of you that might be on the phone, 14, N for nurse, E for echo, W for William, S for Sam. So again, you need an EADS account in order to tap into slides and other materials that we're going to load. And we know this can be a bit of a process. However, this is the platform we use for all of our trainings. If you haven't discovered that yet, we ask you to do that because it will come in handy for the September 17th training. And I think we have a request to repeat the EADS code, and that's 14 news, N-E-W-S, 14 N-E-W-S, S for Sam.
This is Nirmala. I would really urge you to get your EADS account because I would love for you to get the supplemental documents that Angela is going to upload, which has the resource sheet and the screening instrument that I talked about.
Yes, absolutely. We know it's a lot to load into the back end, but going forward, you will need EADS for all of our fall series trainings, which we'll be putting out a save the date flyer here soon. We have 8 planned. Nirmala will be giving us trainings for at least 3 more topics, suicidality being one of them, substance abuse and the older adult, and doing a comprehensive geriatric assessment. What are the components to actually do a well-rounded assessment for your geriatric clients? We are past the hour. I'm going to thank everybody, including our speaker, our presenter, who did a fantastic job to rearrange her schedule this morning. Our technical problems started last night, folks. So again, thank you all for sticking with us, for tuning in, and we will see you when we see you. Take care, be safe, be well. Bye-bye.